koutou tuatahi ake. Ka mihi o ki te mana whenua ki a te Aotearoa moku ake. Ko Aotearoa te pai maunga whakaruru, ko Waikanai te ara whakaoru, ko tangata tiriti te iwi, no aorangi aku tipuna. E whānau mai au e Wanganui, e tipu aki au e Waikanai, kei ototahi au e noho ana. Ko Anna Stevenson, taku o ingoa, he tākuta o ki te mana ora ki te poari hauora o Waitaha. Ane tētahi whakatauki nui ki aho. Ko ao ko te whenua ko ao. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Greetings to the iwi who are mana whenua in Wellington. I'm Pākehā. My ancestors grew up in Ireland and they came over many generations ago. I was born in Wanganui. I grew up in Waikanai. Now I live in Christchurch where I work as a medical officer of health at the Canterbury District Health Board. And the whakatauki that I want to talk about in this talk is about how inextricable the relationship is between humans and the world we live in. I am the land and the land is me. Earlier this year, I was reading a book about the spiritual practice of lament. The book was called Words for a Dying World, and its focus was on climate change. I found a chapter in the book by the Reverend Chris Hurawai, who's an Anglican minister. He grew up also in Otautahi, now lives up near Gisborne. And he talked about pepaha as identity statements, which are not just about geography. But he wrote, these natural features are ancestors. So the river, the mountain, these are ancestors from whom Maori trace their descent. It is in this way that Maori are once again brought into relationship with the natural world. And this reality is reflected in the stories and the histories of our people. So we name these natural features. They are given personalities and stories. They are treated as a living, breathing part of genealogy. I think what Reverend Hurawai was suggesting was that in one sense, these rivers, these mountains, these geographical place markers are as alive as the people in this photo. Me, my mother, my grandmother, my great-grandmother. And in the same way that I tell stories about these people from my whānau, I tell stories about the places where I grew up, the places that I was born, and I care for those places in the same way that I care for my whānau members. So that's not going to be a new idea to most of you, the idea that there's a significant relationship for Maori with the whenua. But the thing that particularly struck me about what Reverend Hurawai was saying was the specific linking of pepaha with the practice of lament and with climate activism. The idea that for many Maori, when they recite their pepaha, there is grief associated with the loss of the whenua they are linked and bound to. Maybe they lost that land from colonisation processes, or maybe it is predicted and anticipated that they will lose it from the effects of climate change, which you could also argue is an impact of colonisation. Part of the lament structure is about acknowledging the pain and its cause. We can't make the changes that we need to make until we own and grieve the pain. Reverend Hurawai talks about how knowing your pepaha means knowing the land you are in relationship with. And eventually, that knowledge will lead you to concern for the land in the same way that we are concerned for our families and our own bodies. A pepaha guides us to kaitiakitanga. And once you fully understand that, the activist movements of our time, such as what has happened at Ihu Matau, they seem like the only reasonable response to the threat of inappropriate development. Ko te whenua, ko ao. So I'll come back to pepaha later on, but moving on to the subject of this talk, Debbie Wilson contacted me and asked me to do this presentation. She wrote to me, it strikes me as being alarming that not only do we have a climate that is and will disrupt services, we may also have a service delivery model that does not meet the changing requirements with respect to climate change. And she asked me if there were any policy processes that might be useful, in particular health impact assessment. And I think she asked me because she knows that I've been championing what's called a health in all policies approach for quite a few years now. And anyone who's familiar with that approach will know that health impact assessment is a major tool of that approach. So this is a standard definition of health impact assessment. It comes out of a 2006 best practice document. a combination of procedures, methods, and tools by which a policy, program, or project may be judged as to its potential effects on the health of a population and the distribution of those effects within the population. Health impact assessment identifies appropriate actions to manage those effects. And just a quick shout out to Rob Quigley, who's mentioned in the citation there. Many of you will know him. And he's been really heavily invested in this space right from the very beginning. And in fact, Rob was one of the team who went around the country for 2 years training New Zealanders under the mandate of the Public Health Advisory Committee, which no longer exists now, and trying to help people understand how to do health impact assessments. He helped write the document, and in that document, the authors wrote what they thought the values for health impact assessment should be in New Zealand. And they thought it should be things like commitment to the principles of the Treaty of Waitangi, sustainable development, equity, public participation, and working cross-sectorally. And I was talking to Dr. Raymond Pink about this. We worked together on a project I'll show you in a minute or two, about 15 years ago now. And we were reflecting how back in the day, this seemed like really radical stuff. And now it's not quite business as usual, but it's pretty standard, isn't it? So the HIA that Raymond and I worked on together was the health impact assessment on the Greater Christchurch Urban Development Strategy. And that was started from a conversation that I had with a city council colleague in the training that I did with Rob back in 2005. And Terry Moody and I met at that training, and we got talking in the taxi on the way back to the airport. And we said, really need to get on and do something about this. And as that happened, that urban development strategy project had just gone out for public consultation. And so we seized our moment and got into it. And the quotes I put up there come from the formative evaluation that we did on that project. And they reflect what I think was the key learning for me out of this project, which was the importance of whakawhanaungatanga, even in something like a government policy project. So people who'd only ever known each other from the front page of the press, the daily newspaper in Canterbury, taking pot shots at each other about conflicts they were having. They came back and they said things like, this is the first time that all of us working in waste from councils in the private sector have actually all been in one room together to talk about this subject. Or one of the Environment Canterbury scientists said, the greatest value for me was understanding what you do in public health, because I had no idea. I'm a water scientist. What would I know? So for me, that was really a critical learning. And since then, the bulk of my public health career has been focused on trying to create and nurture relationships and partnerships, specifically between the Canterbury District Health Board and between the Regional Council, Environment Canterbury, and Christchurch City Council. And the goal is to translate the language and the culture of each sector to the other sector, focusing on how we can work together to create win-win situations with respect to the health and flourishing of our communities. And inevitably, that's led us to think about this concept of co-benefits, which for most of you in this room will be completely ordinary, completely assumed by you, but it's actually a really little known subject, or certainly not well implemented in other sectors. So Debbie asked me, had anybody done any health impact assessments on climate change? And I had a bit of a look around. I got some help from an information technologist. I asked on a couple of listservs, and I think the answer is that there's been very few done. There was a review of 400 health impact assessments that have been done in the United States. Only 12 of those specifically looked at climate change. But I came up with this really interesting one from 2010 done by the Alaska Native Tribal Health Consortium Centre for Climate and Health. And this was true citizen science stuff, and you can see the kind of information that was coming out of that was really relevant to the context and locale that these people were living in. There's about 700 people living there at the time of this HIA back in 2010. The most recent information I can find about this Kivalina, otherwise known as Point Hope, which is kind of ironic, it's down to about 500, I think, and it is literally being washed away by the sea, and the ice is melting, and they can no longer get the food that they have had for many, many generations. Other ways this has been addressed in Europe, the European Union has had a directive for many, many years that you need to do environmental impact assessment on big infrastructure projects. And in 2014, they brought in a requirement that you needed to consider human health. And you can see that there's been some training done in that. This is a 2019 training that was offered. And I came across a paper from this year by Ben Cave and Associates, one of the trainers there, where they had gone to look for case studies of where this had actually happened. Where has health been considered in the environmental impact assessments? And I think you could summarise their quote or paraphrase their quote saying there might be some, but even though we're working in this field pretty much full time, we can't find any, so there probably isn't any. There has been one really significant HIA on the health impacts of climate change, and it was done in 2008 in Western Australia. And the authors, the project leaders of that one, went on to use the framework they developed and trialled it in some Pacific Island countries, in Solomon Islands, and Nauru and Vanuatu, and it worked well enough that they wrote it up into a paper so that if anybody else wants to pick it up, this is the how-to guide for this subject. And then the 2008 HIA became one of the key pieces of evidence that fed into this Climate and Health Western Australia inquiry, which just was released at the end of last year. And the lead author for that, Dr. Taran Weeramanthri, said that to his knowledge, this is the first statutory inquiry anywhere in the world focused on the health impacts of climate change. The authors were interviewed, and he said to them, you know, your project was really, really good, and the risks that you identified, the key threats that you identified, they're still 100% relevant all of these years later. And he obviously liked their methodology enough that in Appendix 3 of this inquiry, he recommends that an HIA be done. He's calling it a vulnerability assessment, and he gave terms of reference and a scope and an ETA of 1 year for that project to be delivered. And then the requirement is that once that has been delivered, a climate change adaptation plan for Western Australia's health sector is to be developed based on the results of that HIA. So I'm aware that around this country in various DHBs, certainly not all of them, but in some of them, some people have already started doing work of this kind. But it's not nationally led, and it's you know, it's pretty ad hoc is not quite the right word, but it's not a systematic approach to what's going on in the health sector in our country. And you know, in Australia, they were really interested in the health impact assessment work and have been recommending it. And these are the reasons possibly why they might have been. These are the best principles that came out in April 2021 this year. The idea that public health is placed on the agenda of all sectors, that risks to human health are anticipated and mitigated, co-benefits are identified, the emphasis on equity, which is rare in other sectors, public participation and decision-making is facilitated, and hopefully you end up with reduced burden on health services and a contribution to healthier and more resilient communities. And in our own practice down in Canterbury, where I'm based, the evaluations that we've done on the HIAs and integrated assessments that we've done all fall broadly into these categories. Whakawhanaungatanga, as I've already mentioned, is an absolutely critical one. We found that the participants who are involved in our processes really take ownership of whatever the project is. We found that the work genuinely does improve the plan or the policy, whatever the project is that we're working on, and that's agreed by all parties involved. And really interestingly is this process of joined up learning. When you're working with people from other sectors, people who you may never have worked with before or you've never talked to them before, you start to understand things in different ways. And this is a quote from our original HIA, but it could apply to all of the ones that we've done over the last 15 years. Sustainability has not traditionally been considered a public health issue, but during the HIA process, a new vocabulary has developed in the public health workforce around traditional sustainability issues, urban design, peak oil, and active transport. But nevertheless, HIAs haven't been done very often, specific health impact assessments. And the Ministry of Health did have a health impact assessment support unit for a couple of years, but then that disappeared. They haven't been funded, they haven't been contracted, they're not legislated for, except for in Canterbury, a short period when they were legislated in the Canterbury Earthquake Recovery Authority legislation. And I guess that's because they're generally not been understood to add value. So you've got to ask yourself, how did they end up in the Canterbury Earthquake Recovery legislation? And that was back to this whakawhanaungatanga concept that it was all based on relationships that we had developed with the councils well before the earthquakes, and many of those staff transferred into SERA. But because it was a real struggle generally to get HIAs taken seriously, in Canterbury at our public health unit, we moved more into this health and all policies approach. And this is the definition that we use for health and all policies, and RQ stands for Rob Quigley, so once again, he turns up. A structured approach to working across sectors with communities on public policies and projects promotes trusting relationships. That's really critical, that trust component, and engages stakeholders to systematically take into account the implications of decisions, Health and all policies seek synergies, co-benefits, win-win, to improve societal goals, the shared goals that we all have around population health and health equity. And the work that we've done very loosely looks like this. We've got a whole lot of the projects that we've worked on the top of the slide there. And I guess most importantly are the institutional and government arrangements that we've set up over the years. And the ones that we're particularly happy about are the joint work plans that we've set up with the Regional Council and our local Christchurch City Council, where we work on agreed projects together, the ones that we think we can work on for a win-win for each other with the shared goal of health for our community. And we have governance meetings between the various boards and councils. We have senior management meetings for each party, at least annually, often 6 monthly. And the people who are actually doing the work meet as regularly as is required to deliver and report on the projects that they're doing. It's a small body of work by a global scale, I guess, but it's really high quality, and we know that because it's very well evaluated. And what's been really interesting and kind of nice for us over the last year or so while we've been embroiled in COVID is that public health has been missing from this partnership. They've been missing from this table, and our partners have noticed. And they have come to us quite explicitly on several occasions now and said, you know, when are you guys coming back to the table? We're back to business as usual. We know that apparently you're quite busy on COVID, but we need you. And we've realised how much we've come to depend on the public health voice. So that's been, that gives us a lot of hope that this is a really useful tool and a useful way of working. And that is backed up by increasingly by the academic work that's coming out. This is from a paper that came out in the Lancet in February this year, the public health implications of the Paris Agreement. It's a modelling study. And what it compared was 3 different policy approaches. It compared a business as usual policy approach. It compared an approach which had a kind of generic sustainability focus. And then it compared this health in all climate policy approach, where you put health issues at the centre of the design, assessment and implementation of any climate change policies. And what that found was that compared to a business as usual approach and compared to a sustainability approach, a health and all climate policies approach delivered much better results for health and well-being and for our projected ability to actually reach the Paris target of well below 2 degrees Celsius in a way that maximises good health and well-being. So the slide that I put up there just relates to active transport. The health and all climate policies approach are the blue bars, and the sustainability policies approach are the red bars. And I think about this, and I think if we took this back to New Zealand, if we look at the report that's just come out from the Climate Change Commission, where health is really not featured hardly at all, and if we think about another report that came out earlier this year, actually privately funded, about the impact of type 2 diabetes on our health system, and estimated that type 2 diabetes, which has got 3 risk factors: increasing age, inadequate exercise, activity levels, and inadequate diet, the cost of that to our health system now, it's about 5% of presentations are related to type 2 diabetes in some way, and that's projected to get up to about 10% over the next 20 years, and will take up around about 9% of vote health within the next 20 years, which is absolutely phenomenal. And if you think once again about this co-benefit approach, if we had a true health and all climate policies approach, we would be bringing those pieces of work together, the Climate Change Commission's work, the type 2 diabetes work, and we would be trying to go for best practice outcomes in both of those spaces, which would give us much better outcomes on all of those fronts. So what do you need if you're going to make that work? 3 things broadly. You need political and organisational will. You need to connect to established things. You don't want to start a whole new thing. You don't want to keep going again. And I keep going on about this concept of relationship building and whakawhanaungatanga, and I keep going on about it because we don't do it very well. But what do we know that we have done well? We know in COVID, we know in lockdown, that this government really went for a whole of government approach. And if you were using other language, you could have called it a health and all policies approach. They looked at particular determinants of health and they did their very best to mitigate the impact of the lockdown on those determinants of health. It wasn't perfect, but it was one of the better responses globally. Another example of where political and organisational will is increasing and becoming more and more evident is around the achievement of equitable health outcomes for Maori. And there's this line in the Y2575 report from 2019 where it really specifically says that health for Maori, health equity for Maori, is a responsibility of every sector. It's not just a health sector response. So we're back to this whole of government approach. And if we think about how we can connect to established goals and frameworks, New Zealand is a signatory to the Sustainable Development Goals. We provided our voluntary national report back in 2019, which emphasised how Treasury's work on the Living Standards framework matched up with the wellbeing budget, which matched up with the Sustainable Development Goals. And there was ministerial level support for an alternative report, the People's Report, on how well we were doing around the SDGs. And that People's Report wasn't quite as positive, perhaps, as the government's voluntary report. But it did state in that People's Report, collaboration across generations, across government, business sectors and civil society are essential if the vision of a more just, equal and sustainable world is to be achieved. And so I guess I'm arguing that although this is currently under-resourced, this is a moment in time when we could definitely utilise these health and all policies tools and advocate for them to become standard practice. Treasury's Living Standards Framework, another established framework that we've got, is being updated, say Treasury this year, to better reflect Maori and Pacifica worldviews, to better reflect what matters for child wellbeing, and the different ways in which culture contributes to wellbeing. So all of those things there, the 12 domains of current wellbeing, are things that we in the sustainability field should be really interested in, and certainly public health we're really interested in. So there's a really clear nexus there. And then the final thing that I want to raise is the Public Service Act, which came out last year. I think this is on page 84, might be page 86. The whole of this act is really talking about whole of government approaches. It seems to be a really strong push from this current government. But this idea of a long-term insights briefing seems really relevant for us. The requirement to provide information and analysis on medium and long-term risks, long-term trends and opportunities that may affect New Zealand and New Zealand society. And this seems to me to be very similar to the work that's been carried out in Western Australia on climate change and health. And I think that we could argue that the Minister of Health could present a briefing like this to our government on the health infrastructure system that we have, not just the buildings, but the actual delivery of how we deliver health in this country, and do a vulnerability impact assessment on that and present that back to the government as part of this long-term insight briefings. So I'm really hoping that there are people in the audience who can advocate for this kind of work to be done. And then the last thing that I want to do is speak to this renaissance, that's the word some people are using, around Te Reo Maori. And this was from the Maori Language Commission's week that they do every year. This is what they did last year, how to introduce yourself, a 49-second video on how to do your pepaha. Very simple, very much a starter, but it's a start, and over 1 million people apparently engaged with this program last year. And I've already talked about how pepaha is a tool for climate activism, but of course, it's also a relationship building tool. And in the act of learning to introduce yourself in a new language, we potentially humble ourselves to learn new ways of thinking, to understand new knowledge, and perhaps even we learn how to work better together. So there's heaps of other things that I could discuss here. And I acknowledge that each of the things I've talked about are in themselves quite fragile threads, but I hope that combined together, they can form a little bit of a rope that we can use to utilise to build the partnerships that we need to create the changes that we need. What might stop us from doing that? And I'm speaking to my colleagues in the public health sector here. This is a study from Australia, 2017, and it looked at how the public health sector had engaged with other sectors, intersectoral actions, where they were trying to work with other partners. And essentially what they found was that we were really bad at it. Engagement between the health sector and the sectors that truly impact systemic socioeconomic inequalities is very limited. The phrase health imperialism has been tossed around, but I'd also suggest that there's a failure of imagination at times, a really narrow understanding from health around how the rest of the world works, a suggestion that we know everything and we know how to do it best. But actually, that is just not true. And there's plenty of people in the room here who can testify to that. The Australian review, I think, is complemented by some of the reviews that have been done on the health sector's response to COVID in New Zealand over the last year, where it's been noted again that in health we have struggled at times to partner well with other agencies. And perhaps a little bit defensively, I would say that that's not just a health problem, but it certainly is a health problem, and it's something that we need to work better on. We know what makes intersectoral partnerships work, and it's very much around developing a shared mission. It's around a broad range of participants. It's around leadership that inspires trust and confidence. That is, in fact, the definition of health and all policies, if you remember from a few slides earlier. It's about excellent communication, and we certainly saw that through COVID, and we continue to see it from our government. It's around the balance between maintenance and production activities, thinking more widely than just our own sector, thinking about other people's contexts, And then evaluation is really, really important. And I would argue that our Health and All Policies program in Canterbury, of course I would argue this, has done these really well, and it continues to do these really well, including the maintenance and production activities. But it is also fair to say that for us in Canterbury, we have been absent from the table for the last year. We're hitting that time management issue of urgent and important. COVID has been the overwhelming urgent and important issue in our room that pretty much all of our time has gone to. But climate change is the bigger issue in the room. And it is just as urgent and just as important. Debbie called me to speak about this issue because she knows I've been leading the Health and All Policies team since it began in 2011 in the Canterbury District Health Board. But in preparing for this talk, it really did come home to me how little work I've done in this space over the last year. And so while I was thinking about this whole idea about a vulnerability assessment for our DHB, I thought I'd ring up my colleagues in the council and see what they're doing. And it turns out that they, like some other councils in the country, have been working on what they're calling a risk screening or a vulnerability assessment. It's completely draft, not anywhere near the public yet. But when I was in conversation with them last week, they were saying, look, we desperately need health at the table. We know that we're missing the health voice here. And just today in my emails, I got an email from a very senior manager in the council saying the same thing. We know you're really busy and with COVID, but how do we get you back to the table to do this work, which is arguably at least as important? So while I was trying to prepare a talk for other people, what I've done in the preparation of the talk is give my team back at the DHB quite a big job to do. And I've really given myself quite a talking to about where my priorities need to lie over the next wee while. I guess what I want to sum up with is to say we have the tools, we have the information that we need, we have examples of how to do it, we know how it's done, we have the opportunities. It's really important that we get on and do it, and we are running out of time. This is a report that came out Thursday last week, The Limits of Livability, and it's just looking at the impact of forest fires on public health, forest fires that are directly related to climate change. You can see the quote on the front there, if this is what we experience regularly, we just can't live here anymore. Worldwide, governments must act to prepare public health systems for the impacts to the public from recurring air pollution episodes from fires caused by the climate crisis, deforestation practices, and poor land management. And last night I was watching that really quite depressing documentary on Netflix about planetary boundaries and how far we have exceeded so many of them. We have run out of time and we need to move a lot faster. Just like COVID, climate change is very much in the urgent and important grid. So to sum up, Debbie asked me what was being done around climate change mitigation and adaptation in Aotearoa's healthcare sector in the high-level policy space. Where are we going? How could we get there? And I think where I've got up to is that there's no formal assessment at a national level of the health system's vulnerabilities in New Zealand with respect to climate change. There are some assessments going on locally in different DHBs, but nothing joined up. And globally, that is not unusual. But we do know how to do it. We have plenty of enablers, and I've just gone through a few of them. We do know what the key barriers are. And the fundamental barrier, the fundamental issue is around language, not just linguistic language, but cultural and sectoral language issues. And ultimately, whakawhanaungatanga is fundamental to this mahi. So I'm just going to finish coming back to that whakatauki.